All right, good morning. Thank you all for coming to Grand Rounds, Heart Center Grand Rounds. So this morning it's one of our pleasures to have back a familiar face. Dr. Tam is going to talk to us today about vascular surgical oncology, which is perhaps a field she's creating. It's a pleasure to have Tam back. Tam originally from Canada, where she trained at McGill for medical school, and then she ultimately finished her training at Baylor here with vascular surgery. She's worked, I think, at every institution in the medical center, perhaps except for the dental school. So she's been in faculty at UT. We're on faculty together at Baylor. She was then faculty with us here at Methodist, and now is full-time at MD Anderson, kind of forging a new frontier. So Tam, thanks very much for coming, and look forward to your talk.
Thank you very much. Good morning, everyone. It truly is a privilege to be standing here in front of you to give this presentation. I was a fellow here in 1998, and I still remember the Favreau Tower, those of you who've been around. It's no longer there, I think, but I used to live on the 3rd floor, I think. Truly a privilege. Thank you for the opportunity to talk to you about what I sort of term vascular oncology. Now, for those of you that may not be familiar with UT MD Anderson Cancer Center, it was created in 1944, and MD stands for Monroe Dunaway Anderson. And you can see the stats there. We have treated over 1 million patients at the center, and we are over 1,500 faculty at the center. We have a lot of volunteers, and we'll have a lot of trainees as well. We don't have as many beds as Houston Methodist, only about 654 on average on the inpatient census, but we do have a lot of clinical active research protocol. The objective of my talk, really, I think Eric asked me to come over here and talk to the group, primarily to try and make sure that I do have a practice at MD Anderson, because we're trying to get Eric's group to send us vascular resident over there for training. So I think he's want to check it out and make sure that I have at least the numbers or the cases for the residents. That's sort of primary objective number one. But I would like to go over a very clinical talk, really, review the management of the common complications in cancer patients. And the two most common vascular complications in cancer patients are really the problem with venous thromboembolism, or VTE, with DVT and PE. And also something that we are seeing more and more of, because patients are living longer and longer, is really the radiation-induced vasculopathy. And then the latter part of the talk will really be to kind of showcase what we do a lot of the times, and we're privileged to do it because we're a large center that have multidisciplinary teams that allow us to perform the large intra-abdominal sarcoma or tumors that involve blood vessels within the abdomen. And that would be the latter part of my talk. So this first slide just put everything in perspective. As you can see, cardiovascular disease is the #1 cause of death, and cancer follows just a little bit behind it as the #2 cause of death. And this is a table from 2011. But what is it that causes death in cancer patients is really not well defined. This table shows that most patients die really from progression of the cancer, and that is organ failure from not being able to breathe, from lung cancer, organ failure from liver failure, if it's a hepatocellular carcinoma. So the majority of them die because of the progression of cancer. But the two other most common reasons why they die is really complications with arterial thrombosis and venothrombotic problems. And that's what we're going to go over. So this slide really showed the importance of DVT and PE in killing patients who have cancer. As you can see, this graph shows that the probability of dying if you have VTE and cancer is very high by 180 days, compared to if you only have DVT and PE without cancer. So having a VTE in a cancer patient raised their death mortality to greater than 4 or 7-fold higher. And it is thought that about 15% of all cancer patients would develop VTE at some point in time. And if you have VTE, About 20% of patients who present with VTE will be found to have cancer, of course. So let me show you an example of a typical patient with cancer and VTE. This is the case of an 85-year-old woman who has had colorectal cancer treatment. She had surgery about 2 years prior to her presentation, but then she had a recurrence. And so she went on to receive chemo and radiation for her recurrence in the pelvis. And several days, she presented to the clinic with several-day history of progressive leg swelling and pain. And when on examination, you can find that she has fairly severe swelling in her right leg. And this CT shows the recurrent in the right pelvic wall. You see this is the right iliac artery and right iliac vein. And the recurrence is adjacent to the blood vessels, extended from the iliac to the femoral area. So this is your typical ultrasound venous duplex scan confirming that there's flow in the common iliac vein. There's no flow in the external iliac vein. And the thrombus extended down to the common femoral vein. And you can see here in the right groin region, there's tumor in the groin, and the common femoral vein is occluded. And scanning further down the leg, we can see that there's actually flow through the femoral vein and popliteal vein. So it sort of indicates this is slightly different than your typical spontaneous iliofemoral DVT, which typically would involve the entire femoral vein and popliteal vein, involving the iliac vein as well. Whereas this patient, her primary disease is likely tumor compression of the vein leading to thrombosis in the area. So what to do? Well, even though she may have cancer, she's 85, but she was very active, and so we thought of proceeding with intervention. So we took her to the angiographic suite, and this is the venogram with her in a prone position. You can see the flow in the femoral vein, and then this is the DSA of the flow being interrupted above the inguinal ligament. We pass the catheter through the thrombus into the common iliac vein, and you see the IVC with good flow. So we left a catheter inside the thrombus for catheter-directed thrombolysis, and she received that over a 24-hour period. And this is her lysis, post-lysis image the next day. We had recanalized some of the external iliac vein, as you can see, and then we balloon the area. But even after balloon angioplasty, you can see the vein is not looking it's not looking good, and so we went ahead and also put a stent in. And likely she had a combination of compression in addition to the thrombus, which has been lysed. So that's the post-stent image. And she did quite well post-intervention. Her swelling went away. She was kept on Plavix and Lovenox, and she was able to finish the palliative radiation to her right pelvis. And she remained very independent, ambulatory at home. She was seen back in the clinic 4 months after the intervention. And like most cancer patients with recurrent metastatic disease, she passed away about 18 months after the procedure. How about this other case? This is a case of a 68-year-old woman who underwent temporal resection of a large GBM tumor. She had post-op radiation and chemotherapy, and 2 months after her surgery, she came into the ER with shortness of breath and chest pain. And so, of course, the suspected diagnosis would be a sort of fairly large pulmonary embolus, most likely. Her blood pressure was 79/56. These are her vitals. She did not sat very well on room air, so we put on oxygen, supported her. Her EKG did show some changes, and her echocardiogram also shows some RA and RV dysfunction. And let me show you the CT scan. So these are her axial images. You can see there's a big PE on the left, and then lower down in the right pulmonary artery, you can see other thrombus there. Other views showing really settled PE on both sides. see more thrombus on this view. So I guess in the ideal world, perhaps here one would consider surgical thromboembolectomy, percutaneous mechanical thrombectomy, catheter-directed thrombolysis. We have found that in our institution treating cancer patients, because typically with a GBM you may not have the greatest long-term outcome prognosis, we have tended to be not as aggressive. Nevertheless, we supported her with preload support. We gave her IV heparin, and she actually got better with just medical treatment and medical support. And the question is whether, the other question is whether we should have placed an IVC filter for extra protection. And because we have found in our institution the management of PE is really very varied. It depends on who gets consulted. If it's a cardiologist, then it may be one way. If it's a vascular surgery team, it may be another way. If it's an interventional radiologist, it may be a different way. Or we actually also at times consult the pulmonologist. So we actually have got together, and just last Saturday we sort of assembled a team, and we are hoping to really progress and move towards building what we call the, what has been termed as the PERT team, Pulmonary Embolism Response Team, which really has caught on across the nation. And hopefully with the team, we would be able to form a more standard of care for patients who come in with pulmonary embolism in cancer patients. So what about the role of IVC filter for that patients with saddle embolus? You always hear that, they have a little pulmonary reserve. We might as well just go ahead and drop an IVC filter in, even though, we're going to keep her on anticoagulation. Well, there's really no data to support that. And the PREPIC-2 trial, recently published in the beginning of the year, really sort of confirmed that there is no role for IVC filter if the patient can remain anticoagulated. And you can see in this table the recurrence rate of VTE in patients who were randomized to getting filter in addition to anticoagulation was really no different than people who were simply on anticoagulation. So no role for IVC filter in patients with PE who can remain on anticoagulation. So moving on to arterial thrombosis. So VTE is probably much more common than arterial thrombosis. But arterial thrombosis in cancer patients have been thought of as kind of the last, an event that will portend impending demise of the patient. And so up until recently, most patients have been treated very conservatively in that, if you present with arterial thrombosis, then likely you will die soon from your cancer, and there has been no treatment advocated for those patients. We review our own data at MD Anderson over a 10-year period. We had 74 patients who presented with acute limb-threatening ischemia, and these are the demographic. There was 40 women, 34 men, and you see the different types of cancer. Most common is actually GU and GI, and lung cancer is about 20%, and then the other cancer down here. And the one chemotherapy agent that's been associated with a higher risk of arterial thrombosis was the cisplatin-based chemotherapy, and patients were on it 24% of the time. So what did we do for people with acute limb-threatening ischemia? We did surgery in 29 patients. 14 patients had percutaneous catheter-based intervention, and 7 patients had a combination of catheter-based intervention and surgery, and 18 patients actually had anticoagulation alone, and 6 patients had no therapy. So expectedly, our amputation and survival rate at 1 year were fairly high. Only 27 patients survived. So most patients die within a year. We had 11% amputation rate. And the highest death rate was actually in patients who had an amputation. So it's kind of self-selection a little bit. How about this woman? If you can imagine, this is a 39-year-old woman who's actually a non-smoker. She's been cured of her cancer. In 2007, she had adenocarcinoma of the cervix. She had radiation treatment, she had resection, and also had sort of extensive ureter reconstruction because the tumor was involving the right ureter. So that was several years ago, and she's currently without evidence of cancer. And she presented to our clinic with 1 month history of insidious right leg claudication. She had no palpable right femoral pulse, no pedal pulses on the right, but she did have very normal left femoral and pedal pulses. And those are her numbers. Right ABI was 0.49 and left was normal. So young woman, non-smoker, prior history of radiation and surgery. And this is her CT scan that she had for surveillance of her cancer, actually. So it's not a dedicated CT angiogram, but you can see the thrombus inside the common iliac extended down to the external iliac artery. This is the big bladder because they fill it up to look at the ureter. And then there's reconstitution of the right femoral artery. So although she had had symptoms for about a month, we went ahead and attempted endovascular procedure first. And you can see this is the arteriogram. Went up and over the entire right common and external iliac arteries were occluded. We were able to cross it. And so we put down the angiojet. Most of you are familiar with the angiojet system. We suck out the clot, and this is her picture after mechanical thrombectomy with the angiojet. You can see she still had residual thrombus. So we went ahead and left a catheter within the right common and external iliac artery for catheter-directed thrombolysis. So she required about 24 hours of thrombolysis. And then we took her back, and there was some residual stenosis, so we went ahead and stented it. And this is her final picture after revascularization. So she's young. She's only 39. She had endovascular, successful revascularization. So we looked up our data in the last 3 years where we started doing more of these endovascular procedure. And this is a sort of very early, small group of patients. But you can see we presented this at our meeting last year. We had 13 patients who had iliofemoral occlusive disease. And the table showed the time interval from the time they had radiation treatment to the time they developed occlusive problem. You can see that the average is 10 years. The median is 8 years after radiation. So these things don't happen early. They happen over time. These are the different types of cancer in this group of patients. The vulva cervix in women is the most common type of cancer that will cause iliofemoral occlusive disease. And then the anorectal, other cancer down there with the sarcoma as the last group. So how do we treat them? Well, like most other patients, we attempt endovascular procedure in most of them, and we did that in 5 patients. Some patients had a combination of iliac disease and distal femoral disease, so we did hybrid revascularization, a combination of iliac stenting and arterectomy of the femoral, and then stenting of the SFA. And surgery only in 2 patients, and then medical treatment only in 1 patient. So our outcome is that 1 patient died, and this actually was a young woman who had cervical cancer, and she died not of her cancer. She was actually cured from her cancer over 6 years, I think. But she died of complications of radiation-induced ureteric problem, and she developed renal failure and sort of had multiple intra-abdominal sepsis as well. 1 patient required above-knee amputation. That patient had a sarcoma. She had SFA stenting, and the sarcoma was treated when she was in her teens, I think. So she survived 20 or 30 years after her sarcoma and then developed femoral artery occlusion. We stented her, but then she re-occluded and needed an amputation for that. So of all the patients that had iliac stenting, 4 out of the 5 patients actually went on to re-occlude the stent. So not surprisingly, there's a higher incidence of in-stent occlusion in patients who have had radiation. This is our overall result. The primary patency rate is not great, but we were able to reopen most of the iliac stents, but then they went on to re-occlude again. So that patient I showed you, the young woman with a cervical cancer who we successfully recanalized the iliac and stented it, she actually re-occluded a couple of times, sort of every year for a couple of years, and then we took her back and then did a fem-fem bypass instead. And she is so far doing well from the fem-fem. So our conclusion is that radiation-induced iliac and femoral arterial occlusive disease developed several years after treatment, and that there is a high incidence of iliac stent thrombosis. And so the question is whether it really is worthwhile to try and stent them first, or should we just go straight to surgical bypass. Surgical bypass does achieve good limb salvage and appears to be more durable than stent. So the same thing happens to the carotid artery after neck radiation, and that's sort of more well known. What is sort of debatable is whether there's a role for carotid ultrasound duplex screening for these patients who have had radiation to the neck area. And part of it is because the treatment of asymptomatic carotid disease remains kind of debatable in our current literature. And so we also pose the question, is there a role for statin treatment for primary prevention of carotid vasculopathy related to radiation? And we are hoping to enroll patients to really study this in a prospective manner. So we know that carotid intervention is more risky for patients who have had radiation, whether they have carotid endarterectomy or carotid stenting. There's a higher incidence of restenosis within the stent with carotid stenting, and there's a high complication, wound complications with carotid endarterectomy in radiated patients. This is sort of to put everything in perspective. The incidence of head and neck cancer is rising. It is the 6th most common cancer overall, and it causes death in over 10,000 patients per year in the United States. The treatment for head and neck cancer kind of varies depending on the sort of stage of the cancer, but it could be a combination of chemoradiation primarily, it could be a combination of radiation and surgery, or a combination of all those three, depending on the stage and the patient factors. This is a bit of a dated paper, but this is a meta-analysis published in 2011 in Stroke, and what it shows is that patients who have had head and neck radiation treatment for cancer are at higher risk of getting stroke. It is as high as 2-fold increase after radiation. And again, the risk of getting an ischemic stroke after radiation is not immediate. It is several years down the road. This is another study showing that radiation compared to surgery, radiation is associated with higher risk of stroke compared to surgery. And this is a review of the Medicare cohort. We had over 6,500 patients who were greater than 65 years old with non-metastatic head and neck cancer between 1992 and 2002. These patients are older. This is a bit dated data because the demographics of head and neck cancer is changing. But nevertheless, this is the data from the late 90s to the early 2000s. And what it does show is that patients who have had radiation alone has a higher incidence of stroke, as shown in this table. You can see on the first column are patients who had had radiation alone. The middle column is patients who have had surgery and radiation, and the last one is patients who have had surgery alone. And you can see that the incidence of stroke is highest in the patients who have radiation alone. It is not as high in patients who have had surgery and radiation, and the reason for that is likely that the dose of radiation is likely much reduced post-operatively compared to the much higher dose of radiation that's given for definitive treatment. So it is an important problem that we must tackle. This graph again shows that the patients who have had radiation only have a much higher incidence of stroke compared to radiation and surgery. So this is the new demographics for head and neck cancer, and I take oropharyngeal type of cancer as an example. This is a table taken from Cancer 2013, our MD Anderson data, and it shows you the different time period, and you can see that the percent of patients surviving is much better in the last decade. So you can see in red is the survival curve for the latest decade between 1995 and 2004, and compared to the 10 years before that. So there's been a remarkable improvement in patient survival with oropharyngeal cancer, and that's in part because of better treatment, but also in part because of the changing underlying pathology. So although in the past we used to think, people with head and neck cancer are all smokers, drinkers, it no longer is the case. The great majority of patients actually now are non-smokers, and there's a very high incidence of HPV-related HPV positivity in these patients. And so this is part of the reason why these patients do better, in part because they're not smokers and they may have less cardiovascular diseases, but also the cancer behaves differently because it is HPV-related. So this also begs the question of making sure that kids get vaccinated for HPV. So this is our data from when I got there. This shows you the patients that we take care of. 60 patients were referred to our clinic with severe carotid artery stenosis, meaning greater than 80%. We had 40 men, 20 women, and 30 patients actually had head and neck cancer. So we see a lot of our patients who present with carotid stenosis in part related to head and neck cancer and radiation. And we've done 26 carotid endarterectomy. We've done 2 combined with neck dissection. We've done a small number of patients who have had previous radiation. And currently we have sent out our patients for carotid stenting to our colleague here actually at Methodist. So moving on to the reason why I sort of moved to MD Anderson is that my love for big tumors or big masses. I wasn't able to do as many open AAA repair anymore as time moved to the endovascular era. So I thought of moving over there so I can take care of big masses. So as a vascular surgeon, we're often asked to help out with the resection of intra-abdominal tumor that involve blood vessels. And the most common reason for removing tumor with blood vessels is due to sarcomatous tumor. And then you have other cancers that may involve blood vessels, such as the renal cell cancer. You can have germ cell tumor, and less commonly ovarian cancer or colorectal cancer. But I'd like to spend the remaining part of the talk just to go over the sort of how we manage vascular reconstruction for intra-abdominal tumor. First, how do they present? Well, typically these patients present with no symptom. Not unlike abdominal aortic aneurysm, they present with an incidental finding on CT scan done for something else. At times they can present with a palpable mass, and pain is typically kind of vague. But if they do present with swelling, leg swelling, or symptoms of claudication, then those are the clues to these tumors involving vein or arteries. But it's not very common. So if I could show you this first case of a patient who is a 61-year-old man, an emergency physician in Mississippi. And he presented with acute left iliofemoral DVT to his own emergency department. And so he had the interventional radiologist kind of take care of him. But this is his tumor that was found after they lysed him and put a stent in. And if you focus on the left side, that's his iliac artery. This is the tumor. And you see they had put a stent in the iliac vein already, and that's his artery. So he was recanalized. He had a stent put in, but then when we found out that he's got a sarcoma that's high grade in the left pelvis. So the importance of referring these patients to a larger center is because the tumor biology matters as to whether patients need neoadjuvant treatment or not. So that patient actually went on to have preoperative radiation treatment and chemotherapy as well. And this is him, his specimen after we remove it. And you can see the tumor involved the iliac vein with the stent removed, and we also had to resect his iliac artery. And he had enough external iliac artery that was redundant that we can actually splice the two ends back together in a primary end-to-end fashion. This is another patient who presented with a vascular complication from the tumor, and he presented with claudication. And you can see here he's a young man who's, I think, late 40s, otherwise very healthy, but he presented to his home emergency department, and he had both iliofemoral DVT and arterial thrombosis. And you can see that he had a stent not only in the iliac vein, but also in the iliac artery. And you can see the tumor, and here is his operative photo. The head is on the top, and this is the groin down here to orient you. And you can see he had a couple of cover stents put in. Sorry, just go back. So on the top, he had a self-expandable cover stent, and at the bottom, it turns out he actually had a balloon-expandable cover stent down here. And we were actually able to remove the tumor and kind of got the adventitia with the tumor, and all we were left here is actually the stent. And so we were done with the tumor here, and if this was a self-expandable stent at the bottom, then he probably wouldn't have needed further reconstruction because it would have kept flowing. But we could sort of, during the surgery, felt that he lost the pulse down here, and it turns out we were mobilizing the tumor, pinching the balloon expandable stent, and as we pinch it, it didn't open back up. So we went ahead and just resect that and placed a Dacron graft in between. He also had segmental sigmoid resection and a left ureterectomy as well, so he needed a muscle flap coverage for that area. So tumor biology is very important when treating these patients with large tumor in the abdomen and pelvis because, as I mentioned before, the sensitivity of the tumor is related to its biology. So, for example, a leiomyosarcoma typically would be sensitive to chemotherapy, whereas a dedifferentiated liposarcoma typically do not respond to neither radiation or chemotherapy. This is another patient with very large tumor. He's 59. He's from Fort Worth, and he had back pain. And this is a CT done for that, and you can see this massive tumor kind of engulfing the aortic bifurcation and the iliac arteries. And so if this was presented to me when I got out of school, I probably would have been salivating and saying, I can do this, no problem, reconstruct the aortic bifurcation, get rid of the tumor, and kind of, be done with it. Well, I've learned quite a bit since then. So he had a biopsy, and it turns out to be a very poorly differentiated neoplasm, and they actually didn't really give a name to it. They call it unclassified tumor, Favor sarcoma. So he went on to have preoperative chemoradiation, radiation for 5 weeks, and neoadjuvant chemo as well. So this is him after chemoradiation. And watch for that big tumor. It has shrunk. Isn't that amazing? It's down to nothing. It's down to nothing. So he still had a tiny little spot, so we went ahead and sort of explore him and resect that tiny little spot because the only cure for sarcoma is really surgical resection. But this patient obviously responded very well to chemoradiation. So again, histology matters, and you can see here the prognosis depends on the histology. This is the survival curves, and you see that the leiomyosarcoma in this table do better than the dedifferentiated liposarcoma. That's sort of the worst kind. whereas the well-differentiated liposarcoma, we call it ALT, has a fairly good prognosis compared to these other two. The other thing that I've learned is that margins matter. So I think as vascular surgeon, if we were to take care of these tumors with vascular involvement, we wouldn't be as much tuned in to the fact that, you can't just peel it off the blood vessel. You got to cut it out to make sure you get good margins. And so this table shows again the survival curve for patients who have margin negative in the black line compared to people who have margin positive for sarcoma. So margins matter. You need to make sure you have negative margins. And there is no role for debulking. No role for debulking. Again, as a vascular surgeon, you see something that looks like it's involving blood vessels, and you think you can debulk it and the patient will feel better. Well, really, there is no role for it, and it's been shown time again and again. This is a bit of a dated slide, but it shows that if you have complete resection, you have a much better survival, and if you only do debulking and incomplete resection, then the survival curve is no different than patients who present with unresectable disease. So what's my algorithm for reconstructing these blood vessels? Oftentimes we go in and the blood vessel is actually completely occluded, and so if the vessel is occluded, then likely you will not need to reconstruct it unless the patient is symptomatic from it. So if the vessel is patent, then we go on to reconstruct. If the vessel is occluded that you're going to resect, then if the inflow and outflow are patent, then I would consider reconstruction. But if the inflow and outflow of that vessel is completely occluded, then really there is no role for reconstruction. These are the different conduits we use for replacing small vessels with saphenous vein, big vessel with jugular, femoral vein I have used for replacing the iliac vein. Internal iliac artery is also a good conduit when trying to reconstruct the external iliac artery. Bovine pericardial patch is what we use most commonly for patching the cava. And rarely we'll use the homograph. Synthetic grafts we use for the larger iliac arteries. And at times for the cava. So these are the cava reconstruction. This is a typical patch. Oops, sorry. This is where we actually didn't patch. This is the native cava, and we actually were able to actually bring it back together as a primary reconstruction. This is a large defect in the cava, so we patched that. This is a tube graft of the cava. So this is an example of a young man, 48-year-old man with IVC leiomyosarcoma, pardon me. He had preoperative chemotherapy, and this is an intraoperative photograph. You see the vesi loop on the cava above the renal vein confluence, and down here you see the iliac artery. And the cava is actually completely occluded. Just show you the preoperative CT scan. You can see the cava here filled with subtumor and some thrombus. And you see the iliac veins also occluded. So for that patient, we resected the tumor and did not reconstruct. This is a patient sent to us from San Antonio, one of our former fellows. And the patient is a 67-year-old woman who had some right lower quadrant pain. And at first they thought it was appendicitis, did a CT scan, and found that she, oops, sorry. I can't find oh, here we go. So aorta, cava, thrombus, tumor. But you can see the renal veins are still patent, although the tumor blocked the entire renal vein confluence. So she had a biopsy of that tumor, and it turns out to be a leiomyosarcoma. She had preoperative chemotherapy. And this is the intraoperative reconstruction. We took out the tumor, reconstructed it with tube graft, reimplanted the right renal vein, tied off the left renal vein. And she's my one good long-term survivor. This is her CT 3 years now since her resection, and you can see the IVC tube graft and kidney still functioning with fairly normal renal function. So this is our data from 2004 to 2014 over a 10-year period. We had 23 patients who had retroperitoneal sarcoma with vascular involvement. Median age was 60, 19 with leiomyosarcoma, 4 with liposarcoma. Preoperative chemotherapy was given in 83% of the time and radiation 43% of the time. Tumor size is 9 centimeter. 13 had combined arterial and venous reconstruction or ligation. And the median survival is 29 months. So those are the liposarcoma. I just have a couple of slides on this other tumor that you may be asked to see at times. It's the germ cell tumor. And this is a different pathology. This is a young 36-year-old man who had chemotherapy and still has residual tumor. And you can see this is his tumor right there. Sort of encasing the left renal vein, and it's as if it's also encasing maybe the aorta. So he's completed his chemotherapy, and now the role of surgery for these germ cell tumor is different. So we need to go in there and remove all of the tumor so that they don't become malignant. So they've been cured, and most of the time when you go in, you remove these tumor, the pathology turns out to be all dead necrotic cells. But there is a small percentage of those patients that will go on to have malignant transformation of that tumor. So it's important to go in and remove the tumor. And you saw how that tumor was kind of almost encasing everything. But typically for these tumor, you can actually mobilize the vessels, and it's really not attached to it. It most of the time come off easily. So you can see this is the big tumor that we removed, and we actually did not have to reconstruct anything. The tumor came off very nicely. This is his aortic bifurcation without the tumor there anymore. This is the cava. So just one slide on the importance of soft tissue coverage. You know, whenever we do these vascular reconstruction, if there's associated, bowel resection and so on, then it's really important to make sure that we have good soft tissue coverage. The omentum is usually our friend, but a lot of the times in our cancer patients is they've taken the omentum already, like for ovarian cancer or colon cancer. But if you have omentum, it is a great flap to place over the reconstructed blood vessels. And this is an example of a rectus muscle flap. So what do I think future research ought to be? I think we are very excited that we're going to hopefully be able to learn how to do minimally invasive vascular reconstruction as our colleagues are getting better with minimally invasive robotic tumor resection. It would be sort of on us to try and go along and keep the surgery minimally invasive with sort of endovascular or robotically assisted vascular reconstruction. And I think our colleagues in radiation and medical oncology will continue to improve on the way they deliver treatment, and that it will be more targeted rather than a wide field treatment. I'm really excited about prevention of thromboembolic complications. There's emerging data that, sort of the chemical DVT prophylaxis that we do is really not very precise. And there's emerging data that if we can inhibit what's called NET, N-E-T, it is a sort of matrix that's excreted by the neutrophils that are activated that have been shown to increase tumor progression, but also has been shown to increase thrombosis. And if you can sort of inhibit NET, then it's been shown that you reduce the thrombotic complications in mice. So this is a sort of a bar graph showing what NET can do, or the presence of NETs in mice with tumor and mice without tumor. So in the white box, you have the presence of NET in mice without tumor, and then it goes up with a tumor that are stimulated by LPS. So these neutrophils secrete the extracellular DNA into the matrix, and it's also thought that that matrix somehow leads to the reduction in the platelet count. And yet at the same time, the patient are more thrombotic, although they become more thrombocytopenic. This is in mice again, showing that the platelet count goes down in LPS-induced mice with tumor, and the DNA goes up in mice with tumor, and that's related to the production of NETs. This is another paper showing that if we inhibit NET with DNase, then we reduce, hopefully, the incidence of thrombosis. This is my second last slide, and it's just so the other way to prevent complications. I think we are doing great. I think this is an important slide. You know, we have done great in preventing the beginning of smoking. This is the rate of cigarette smoking in adults and high school, adults in green and high school students in blue. And you can see that the curve is going down, and currently the rate is less than 20%. And we're hoping to reduce that further down into 2020, that adults, less than 10% of adults will smoke, and hopefully the teenage will also realize that smoking is not good for them. So in conclusions, I think the key factors in the treatment of vascular complications in cancer patients are no different in terms of the basic vascular principles than patients, benign patients. The outcome is measured a little differently in that, survival is sort of important for those patients, and as they survive more, actually they become more greedy. There's actually what we call it the 10-year club, in that, when you become a survivor for 10 years, you want even more than that. So although we may think quality of life is important, and it is important, but for these cancer patients, they want to live longer. They want to live longer. Survival is very important. And the treatment really depends, in part to the underlying tumor biology. With that, I thank you very much for your attention, and I will take any questions.
All right. Well, thank you very much, Tam. That was neat. I think the faculty want to come over as much as the trainees, actually, to be part of that. So, it's funny. When I was in training, I worked with a guy named Mike Silva, who's now the head of vascular at Galveston, and his wife is Colleen Silva, who's a surgical oncologist. And late at night after dinners with bottles of wine, they'd kind of argue about who had the worst or best survivals. And it turns out her survivals were better than his. But sadly, Tam, you got the combination of both vascular disease and oncology. I would think that's got to make it a real challenge to say who gets just kind of medical or expectant management, who do you do minimally invasive, and who do you commit to big open procedures. You want to just comment on that? That must be a difficult decision.
I think it's a bit of a, sort of a decision tree that you go through. Like I said, it depends on the tumor, what kind of tumor. I think the reason why Mike's wife had better survival is because these are breast cancer patients, isn't it? So, I mean, tumor biology is key to the patient survival. But I think in terms of the big resection, you have to make sure that it is resectable. As I said, there's no role for debulking for these big tumor. So, first establish that there's resection. And it is really a multidisciplinary approach. As a vascular surgeon in the community or in a big, Houston Methodist where cardiovascular disease is sort of the #1 team, as a vascular surgeon in a cancer center, it's a little different. I'm not the quarterback. I'm more of a running back. I love football now. I've been in Texas too long, but now that I know the different positions, but just to say that you're not really the leader of the team in the sense to make like the decision, the big decision, but you're certainly very important to support the team, to make it a win team. You have to really consult, and it's really truly a multidisciplinary team where you have the medical oncologist, the radiation oncologist, the surgeon, all get together to really make the right decision for the patient.
Tam, thanks so much for doing this. It's a great talk.
Thank you.
You're kind of in a rarefied atmosphere a little bit in MD Anderson, is that somebody else has made the diagnosis before they send you to the patient. So what keeps me awake at night is missing an IVC leiomyosarcoma that they present to somebody else. They present to us. We diagnose IVC thrombosis. We lyse them. We angioplasty them, we stent them, and then 2 years later there's a diagnosis underlying this of leiomyosarcoma. So, and the same sort of thing if you talk about an angiosarcoma, we see a lot of arteriovenous malformations. My nightmare scenario is that I've been embolizing something for 2 to 3 years and then find out I've missed the diagnosis and it's a malignancy. So are there any clues? How would I avoid falling into these traps? Is it just the finding of a big mass and that's the clue to actually making this diagnosis? Well, what are the mistakes that you've seen made in other centers before they get referred to you?
You know, it really depends on the presentation. I show you a couple of cases where the patients actually presented first with the vascular complication, just like you say, you know, and they get the vascular complication treated. But then I guess it doesn't go away. So typically, do we get a CT on everybody who presented with iliofemoral DVT? Probably not, right? You know, so you got to look at the whole picture, whether the patients had risk factors for those complications. And I guess these patients, the symptoms didn't go away. But how do you really avoid missing it? You know, it's a tough question because it is such a rare disease. I mean, angiosarcoma is so rare. Leiomyosarcoma is not very common either. And so I wouldn't really fault somebody for missing it if, you know, all you present is just with the acute vascular complication. But in the guy that I show you with claudication, he really didn't have any risk factors or anything like that, you know. And so then one would wonder, you know, is there anything else going on? And I think he had pain, but atypical for vascular claudication. So they did a CT because of back pain. So somehow, you know, if you're thorough in the way you work these patients up, you know, with a thorough history and physical, like everything else we do, there will be some clues that you know, further imaging is required, and not just, you know, not after sort of vascular treatment.
There are lots of questions for you, potentially. So, intravascular biopsy.
Yes.
Do you do any of these? I mean, where's the indication? Because we really think we've got a great method of potentially taking pieces out of tumors in a very controlled fashion. Is there a role for that?
You know, that lady that I show you with the IVC leiomyosarcoma that we resected, and she's a 3-year survivor, we actually did biopsy it using the typical needle. I didn't do it, but the IR people did it. But, you know, I would hesitate to do it in tumor that have blood flow, or at least, you know, maybe not in the arterial system. But
So my last question, and I don't know if there's an answer to this. You showed those great pictures of the patient who had the left lower quadrant sarcoma, and you resected everything. But in a patient who has average radiation for a left lower quadrant sarcoma, that the artery is left in there, what happens to that artery 10, 15, 20 years later? Mm-hmm. And I ask this in the setting of what is the risk to us? This week at we focused on radiation to astronauts. Ted Dietrich was here. He's one of the gurus of endovascular surgery. He's got a brain tumor, a cataract, and a carotid stenosis, which he thinks is from radiation exposure. And one of the questions is the irradiated patient a model for what's going to happen to interventionalists down the line if we're not a little more tuned into radiation exposure?
yeah, you know, I think we got to improve our stents. I think, thank you for that question. You know, we've shown that there's a higher incidence of, you know, carotid-induced carotid vasculopathy due to radiation. I've shown you patients with, you know, iliofemoral radiation-induced occlusive disease. So that's well known, and it's not just, you know, 2 years down the road. It's like 5 or 10 years down the road. But, you know, I think we are also getting better with radiation. You know, radiation 10 years ago is nothing like radiation right now. So hopefully with, you know, more focused beam, we won't see those complications as much. You know, overall, it is pretty rare. I would say, you know, we treat a lot of cervical cancer patients, and I don't see them very often, but they do come. And you know, the question is, how do you surveil them? You know, well, I'm not sure surveilling them right now would really make a difference. You know, these people are long-term survivors. So it's important, I think, to educate the patient that, you know, you've had radiation and this might happen to you, you know, 10 years, 20 years down the road. And the key is really how to prevent it. You know, I think better radiation focused beam would hopefully prevent the it's a radiation-induced arterial problem. But maybe there's a role for, statin to reduce the accelerated atherosclerosis that we see with radiation-induced vasculopathy. I don't know.
Just a follow-up question for Dr. Lumsden. So since you stole our vascular sonographer,
Yes.
looks like you're really not using too many ultrasound anymore. So I wanted to see that why you switched to CT that much.
Oh, no.
And hold on. And the second thing is that when you look at and you go back to the vascular ultrasound, we probably haven't paid attention that much to the lymph nodes. So that's another key for Dr. Lumsden follow-up, that we probably have some clue. We just totally ignore them because we're looking for DVT, no DVT, or really tiny sum, and we make incidental findings of lymph nodes or something else. We just kind of ignoring.
Yeah.
So
That's a good point.
thank you.
Yeah, I agree.
But great talk, though.
With regard to, we do ultrasound, though. The CTs really is taken because of surveillance for their cancer. So we sound everybody, too. Carlos?
Well, great talk. I really enjoyed it. And, honestly, going through your slides, and then I was thinking, well, if I had to do this, it's like going through another fellowship or training because you have to learn about some other things. So congrats on the program.
Thank you.
I'm not sure someone asked that question, but do you think there's a role for drug-eluting stents in these radiation-induced, hypercoagulable patients?
We would need a multi-center sort of trial to look at that, but maybe there is, Taxol. It's good for the cancer as well at the same time. There is no data currently, but it certainly begs the question.
We're going to say thanks to Dr. Huynh for being present with us today for Grand Rounds. Thank you, guys.
Thank you. Thank you.